which will be publicly. Okay, now we have the recording on. So this webinar follows a series of learning exchanges on artificial intelligence in health insurance, which also led to the co-creation of an e-learning course that will be publicly available from beginning of next year. And this collaboration between ADB, Amref Health Africa, and GIZ aims to strengthen the capacity to leverage AI technologies, eventually to improve health financing systems, also looking at really concrete applications like include claims management, fraud detection, forecasting, and service quality enhancement. So some of the participants actually from that previous learning exchange are here with us as speakers. I'm pretty sure also we have some of you in the audience. With this in mind, so the objectives today are to present some of the learning outcomes from the previous exchange, look at the preconditions, priority areas for using AI in health financing, and eventually also look at the opportunities to incorporate AI-based solution in social health insurance. With a quick overview of the agenda, so you know where you're staying right now, we're going to have a few opening remarks by the representatives of the organizers, which will majorly, of course, look at why is the topic needed, the motivation to discuss AI in health financing now. We have a keynote that will provide a bit more background on the what. So what are we talking about, to have a joint language. And then the country presentations, which I guess are also really attractive to see really how AI is so far applied, what are strategies about it. This will be followed by a panel discussion to reflect partly also what we heard from the country presentations, eventually then a closing. We can go over to the opening remarks. I would just briefly introduce the first speaker. Akihito Watabe provides technical assistance and guidance to bank-wide operations in health financing for universal health coverage, including digital health financing, health impact investment, and climate change in health financing. He also forces partnership to increase ADB's strategic engagement and collaboration with key stakeholders and initiatives in global health. Akihito-san, over to you.
Thank you very much. Can you hear me?
Yes,
okay, good
perfectly.
morning, good afternoon, or good evening, distinct colleagues and partner and all participants. On behalf of the Asian Development Bank, it's my great pleasure to welcome you all for today's webinar on artificial intelligence for health financing. So this is co-organized with the Amref Health Africa, GIZ, through the Global Alliance for Social Protection and openIMIS initiative, in support of the ADB's Republic Korea, E-Asia, and Knowledge Partnership Fund. So this is a part of the International UHC Day 2025 campaign. The theme is affordable health costs. We are sick of it. So this year is a very powerful reminder for all of us. We commit to universal coverage, in particular financial risk protections for all the people across the world. As Asian and Pacific countries accelerate their efforts toward universal health coverage, the need for innovative, sustainable, and also equitable health financing solutions that has never been greater. Particularly for this digital transformation, it's reshaping the health system worldwide. Today, we stand at the frontier of this new era, where AI is not just a tool, but a catalyst for the change. AI enables us to automate routine insurance tasks, enhance claim management, and also detect fraud and improve forecasting and service quality. So these advantage and advance can help us reduce costs, improve health efficiency, and also ultimately deliver better outcomes for patients and communities. Through these regional technical assistance projects of ADB, we are supporting our developing member countries in Asian and Pacific countries in building capacity and also leveraging AI technology to strengthen health financing systems. So this also includes the co-creation of this e-learning course on AI for health financing with a partner, ensuring it aligns with the relevant national context and policy priorities. So today's webinar brings together experts and practitioners from Asia and beyond to share the key learning exchange outcomes and also discuss preconditions and priority area for AI in health financing, and also explore the opportunity to incorporate AI-based solutions into social health insurance or national health financing schemes. So I encourage all of you to participate proactively and also ask questions and share your insights actively. So together we can enhance the power of AI to make healthcare more affordable, accessible, and sustainable for all. Thank you, and looking forward to the productive and inspiring discussion today. Over to you, Constant.
Thanks a lot, Akito-san. Just to make double sure, do we have a colleague from Amref in? If yes, please come in. Okay. Then elsewise, we can move over to Ralf Rademacher, who is leading the work of the GIZ Global Program, Global Alliances for Social Protection, as well as the sector initiative, Social Protection. And with the global program, he coordinates the implementation of international social protection initiatives at the global and national level, for instance, around the digital transformation of social protection, including international standards and digital public good, specifically openIMIS. And in the sector initiative, social protection, he advises the German Federal Ministry for Economic Cooperation and Development on all aspects of the topic. Over to you, Ralf.
Thank you, Constanze, and thanks, Akito, for the warm words of welcome. Also from my side, colleagues, a warm welcome to today's webinar on AI in health financing. We do meet at a critical juncture. According to the ILO, almost half of the global population still lacks access to social protection, leaving 3.8 billion people without access to a single social protection benefit. And in health, the WHO's latest UHC monitoring report shows that 2 billion people face financial hardships due to out-of-pocket health financing. 1 billion of them pushed into catastrophic expenses. And these numbers are not just statistics, they represent real people. So traditional approaches are not enough. We need innovative, scalable solutions to bridge these gaps. And that's where digital public goods, digital public infrastructure, and AI come in. At GIZ, we are committed to advancing digital transformation in health and social protection to affect change and increase access to social protection and UHC for more people. A key aspect we've been working on for the past decade, together with many partners, is the provision of the open source software, openIMIS, a digital public good, to manage the complex processes of UHC programs and more widely also social protection programs to ease digital transformation efforts. One software tool alone doesn't solve the broad problems we are facing, but harmony between multiple systems is required. So this is made possible by interoperability standards that we work on also with a broad array of partners in the Digital Convergence Initiative. In both these aspects, the upcoming technology around AI offers unparalleled options for improved efficiency and potential accuracy. We've taken this up at GIZ. openIMIS offers a AI claim education module, speeding up claims processing and thus allowing health facilities to receive funding faster and help prevent fraud in health insurance. We also just launched an AI hub for social protection under the Digital Convergence Initiative to support governments to shape their own AI journey in social protection and learn from global peers. In our partnership with the ADB and Amref for capacity development, our goal is clear: to strengthen the capacity of health financing institutions and policymakers to understand, plan, and apply AI solutions in health insurance. The learning exchange has led to the development of an AI learning course for everyone, and will serve as a foundation for future discussions, workshops, and initiatives. Today's webinar is also an extension of that effort in growing a community that leverages AI for faster, more efficient, and more inclusive health financing. Let us use this opportunity to learn from each other, to innovate, and to ensure that no one is left behind in our journey towards universal health coverage and universal social protection. I'm looking forward to today's discussions and to hearing your insights. Together, we can turn the promise of AI into real progress for health and social protection worldwide. Thank you, and let's get started.
Thanks a lot to both of you for these encouraging words. Welcome also to everyone who joined a bit late. We're moving over now from the opening remarks to the keynote. Simona Dobre will provide a keynote today. She's a researcher and data scientist specializing in data analysis, modeling, and the development and implementation of AI models across interdisciplinary domains. She has an academic background in automatic control and computer science, and she's been focusing on AI since 2018, founding also her own company, Dev AIs. She's a technical expert at the Swiss Tropical and Public Health Institute, where she also helped to or contributed to AI models for health insurance workflows, including the openIMIS AI claim categorization module, and she's been supporting AI and innovation-focused learning activities also with together with all of us over the last months. Over to you, Simona.
Thank you, Constance. Can you hear me well?
Yes.
Perfect. Hello, everyone, and thank you for joining the AI in Health Financing webinar. So I'm Simona Dobre, and for the next 15 minutes, I will speak about the potential of AI adoption in health insurance. So my main message today is simple. AI definitely can help organization insurers in order to move faster, target scarce capacity better, but only if we are designing, developing, and implementing it responsibly and build safeguards from day one. Let me start with a brief presentation. So I will not take too long. So what I'm doing now is mainly developing AI models for health-related domain. I have a high interest in having user-centered design projects, meaning human-centered AI. And I have a high interest in developing capacity building related to AI innovation. So why AI matters for universal health coverage and health financing right now? So when we are talking about universal health coverage, we are really talking about financing and delivering challenge under pressure, meaning coverage expands, utilization grows, and expectation rise, while budget and operation capacity remains limited. So health insurance organizations often face increasing transition volume, usually manual bottlenecks in verification and exception handling, but also leverage risks. So, for example, errors, duplication, inappropriate building, fraud, and waste. So this, in the era of AI, needs increasing transparency and trust, because decisions, as already Ralph mentions, affect not numbers, but also people access, and provider payment. So here is why AI matters. So it's not a replacement for policy or governance, but it is an enhanced operation capability in order to speed up high volume processes, to focus human expertise, to detect risk earlier, but also to improve service quality for members and providers. So in order to get specific, we will take a closer look to what means AI. So what I'm generally mentioning in the courses related to AI and AI fundamental is that AI is not did not appear in 2021, but it is a domain which evolved over the last 50 years. So it can be classed in several domains: machine learning, deep learning, natural language processing, if we talk about traditional and discriminative AI, and it has several functionalities: classification, prediction, anomaly detection, and so on. But also from 2021, AI became accessible for everyone. So when we had access to more generative AI, perfect, thank you. So generative AI allows us to generate new data, have communication with chatbots, translation, autocorrection, reporting, summarization, semantic and sentiment analysis. And nowadays, everyone uses AI in everyday work. So where traditional and discriminative AI was mainly related or accessible for researcher or developers, generative AI nowadays is accessible for everyone. Next. Traditional AI has a main objective having high accuracy model, high performance models, and in order to replicate performance of human experts, in terms of time development, it is necessary for at least 6 months in order to have an AI model developed. Whereas when we talk about generative AI, the main objective is to generate new data, which is similar to what human can generate, but it can be deployed really quick. So for example, in at least 3 days, you are able to have a new generative AI model. In terms of AI lifecycle, so the AI model development starts always with problem identification. So what is the challenge? What is the problem that you are trying to solve, for whom, and under which legal and ethical constraints? After you have defined the challenge that you want to save, you will have a look at what data do you need, where does it come from, is it lawful, high quality, representative, and does it fit the purpose? Does it fit the challenge that you want to solve? Afterwards, you will check what are the models that fit your purpose. And in order to integrate that model, you would want to evaluate it and validate it. So in that sense, does the model meet performance, fairness, robustness, explainability, and expectation? And once the model is validated, you would like to integrate it and deploy it in your existing system workflows, but without disrupting operation or rights. So once that you have deployed your model, that doesn't mean that your process is ended. No, you still need to have continuous monitoring and maintenance, and you need to check, does we detect drift? Can we monitor performance? Can we manage incidents? And if there is a problem with the model, we will need to retire the model. So we talk about AI, but also health insurance, the operations, the service delivery chain. So this is the main steps from the delivery chain, from outreach, registration, underwriting, or onboarding, payment collection, claim management, client management, risk management, and exit. So this is, as it is presented, it was presented in the e-learning course on AI in health insurance. So as you see, each step has operations which are associated with it, but also data. So we could develop one or several models for each step of the delivery chain, and we will have different challenges and advantages of the model. If we take a closer zoom, for example, on several steps within the delivery chain, so for example, if we have a closer look at client management, So for example, thank you. So for example, when talking about client management, a national scheme will often face high claim volume, manual verification bottlenecks, and limited capacity in order to spot anomaly claims or fraud or waste early in time. So traditional AI could automate this process in order to detect this anomaly claim or suspicious pattern in order to review and speed up claim verification progress. And in order to be able to develop those traditional AI model, you will need historical claim data in order to train the model. Next. So expanded coverage can definitely stain underwriting and risk oversight due to manual workflows and limited cost liquidity predictability. So in this here again, traditional AI could allow risk classification, claim cost forecasting in order to support benefit pricing decision and early detection of emerging risk trends. In order to train AI models, we will need historical data in order to develop these AI models. Next. So high volumes of registration and client inquiries will create repetitive work and slow triage of complex cases. So for example, when you talk about registration, onboarding, and client management, steps which will need high interaction with the beneficiaries, generative AI could automate routine process, collect key information, and route complex cases to staff. So several generative AI models exist and can be integrated for this. However, you will need to take into account that you will need to readapt the model or fine-tune the model in order to suit your needs. And take into account historical data in order to adapt your model to a specific case. So now what? Turning insights into action. So there are several initiatives, as it already mentioned by Constance and Raf. There are several initiatives which allows capacity building and knowledge management related to AI in health insurance and for social protection. So Constanza was mentioning the e-learning course on AI in health insurance, which has been developed by GIZ Amref ADB, and where I was a facilitator. And the main objective is to create this basic knowledge which allows us, all of us, to talk about the same thing and be on the same page, and with the main idea that we can develop AI models together. Another resource which is already available and was mentioned by Raf is the DCI AI Hub, which supports partners, countries with responsible innovative adoption in social protection, mainly considering 4 action areas: knowledge creation and sharing. So I was part of this process where we have analyzed what are the main risk and rights frameworks related to AI model in production in social protection. And this was a very, very interesting project, and which will be available for all of you in beginning of next year. Digital public goods and standards, where DCI is developing technical blueprints, standards, guidelines for AI-driven solution in social protection, and sharing these via digital platforms, country support, so which will provide policy and technical advisory services. So this will also be available, I think, starting from next year. Constance, yes. And and also capacity building. As we are moving more on AI integrated solution, it is very important to be able to create capacity building for countries and being able to understand what are the safeguards and how to integrate that within existing systems. Thank you for your attention. And if you have questions, I think you can add them in the Q&A section, and we will try to respond to the questions on the run. That's all on my side. Thank you.
Thanks a lot, Simona, and also thanks for the reminder to the audience. So please come in with your questions in the chat box. Yes, thanks. I think your presentation helped us to really relate AI, identify the potential use cases for AI along the service delivery chain of health insurance, and also was a good overview on what are the initiatives, the knowledge resources that can support your journey on AI in the sector. I'm really happy now to also move over to hear really from what's going on in the countries. So we would have 3 presentations now talking about the current setting of digital ecosystems in supporting health financing programs, and then paired, of course, with the outlook and potential areas for AI application up to the either implementation strategy or the actual implementation of AI. I'm handing over to the first presenter for Uzbekistan. Mircha Buga is a chief specialist in the Department for Budget Formatting and Execution from the State Health Insurance Fund, Uzbekistan. Over to you, Mircha.
Good morning, good afternoon. So my name is Mircha Buga, and I am speaking on behalf of the State Health Insurance Fund of the Republic of Uzbekistan. It's a pleasure to join this webinar and to share with you our perspective. So Uzbekistan is a Central Asian country with a population of around 38 million people in 2025 this year. The territory is large, about 450,000 square kilometers. But in terms of health insurance, coverage is implementing now and planned to be completed by the end of 2026. This means that we are moving to a national health insurance system, and that transition places new demands on our governance, financing, and very importantly, our information system. At the moment, our digital landscape can be described as fragmented and still evolving. Different information systems have been developed over time for various purposes. For example, MedRefer for patients flow and provided services, e-contract for purchasing, MedBank for claims management in primary healthcare and hospitals, MedExpress for medicines reimbursement program, and so on. There are also financial and administrative systems managed by other governmental institutions and platforms. So from our perspective, these fragmentations create several challenges. Data flows are often incomplete, delayed, or inconsistent, making it difficult to obtain a single and reliable picture of services use and outcomes at national level. Another important point is that interoperability is still under development. In practice, this means, for example, that claims data, clinical data, financial figures may sit in a separate systems, sometimes duplicated, sometimes missing key information, often requiring manual work. Finally, we face funding constraints for digital transformation. It's not new for countries in this region. Building IT infrastructure, maintaining secure data centers, and of course, recruiting skilled IT and data science staff all require sustained investment. And to address these funding needs, SHIF, State Health Insurance Fund, continually seeks support from international development partners, for example, the ADB and COFI. As we can see on the next slide, the fund plays a central role in contracting providers, processing claims, managing reimbursements, monitoring performance. To do this, SHIF relies on several partially only linked systems that handle provided contracts, eShart, NOMA, first in the list, MedRefer and MedExpress for benefit packages and services, payment rules and claim submissions for MedBanks. These systems are now gradually moving from more manual or semi-digital processes to fully electronic workflows. For example, electronic claims from hospitals and outpatient facilities, and we have really around 6 million claims from hospitals, digital contracts with providers and pharmacy reimbursement system are being implemented further and scaled up. In the next slide, we'll see that the goal is to build an so-called information ecosystem where SHIF can have real-time visibility over which services are being provided to which group of beneficiaries, at what cost, and with what quality and outcomes. The vision is to move from a set of separate systems to a coherent architecture in which SHIF's core applications are connected through an interoperability platform and shared standards. In this planned architecture, SHIF becomes also a data hub for health financing information, claims, reimbursement data, and provider performance indicators. Now all will be captured in consistent formats, making them suitable for both traditional analytics and, of course, future AI application. In this context, AI is seen not an isolated add-on, and we think it's a next step in the evolution of SHIF's information system. Now let's look more concretely at the potential areas where AI can add value in health insurance. The first area is claims automation. We know that AI-based models can support faster claims approvals by automatically categorizing claims, checking for completeness, and flagging inconsistencies. And of course, this can reduce the administrative burden on both providers and SHIF side, shorten reimbursement times, and improve coding quality. In our case, we are using DRG system. A second area is fraud detection, and here AI can help identify duplicate claims quite frequent in our country, or abnormal patterns of service use that may signal abuse or simple errors. So instead of relying only on manual audits, AI models can continuously scan large volumes of data and prioritize cases for human review. AI can support also provider performance monitoring by linking claims data with quality indicators. AI tools can help identify providers that are achieving good outcomes with efficient resource use. Finally, AI can strengthen policy support, identifying areas where resources can be allocated more effectively. All areas that AI can add a value to strategic purchasing and health financing decisions. To make use cases a reality, AI must carefully integrate it into the existing information system framework. The key idea is that AI should build on existing data flows rather than create parallel systems. For example, AI models for claims categorization, fraud detection would be connected to the same databases and applications that SHIF already uses, for example, MedBank. Or AI can help to identify prescription anomalies, assess therapeutic compliance, and forecast drug expenditure in the case of MedExpress model, and so on. Okay, let me now walk you through our possible implementation pathway, how we see the sequence of steps from initial assignment to national scale-up. The last two slides present the implementation pathway divided into main phases, and these slides are based on a shared to us during the workshop in Istanbul example in Dragos Dobre presentation. So first phase, assessment and planning. We'll start by conducting a comprehensive assessment of existing information systems across the health insurance landscape. And this will include SHIFT's own systems that I showed before, provider information system and key national platforms. So we have Uzinfocom, the key integrator in the country. Based on this assessment, we plan to prioritize 2 or 3 high impact AI use cases. For example, inpatient claims categorization and fraud detection, as well as drug reimbursement analytics. During the second phase, we'll define the overall AI scheme design. What data are needed, who will be responsible for each part of the process, what legal documents are required, and how AI outputs will be used in operation and policy decision. In the figure also kindly offered by Dragos Dobre at Istanbul workshop, we can see the possible integration of openIMIS AI module in the claims adjudication process. So at that stage, so we can see that MedRefer will deal with claim submission, MedBank as main engine here. Of course, we'll use our personnel for monitoring and evaluation and manually checking what there, and finally MedBank for payment purposes. So once we have a clear plan, we can move to the scheme operationalization phase. This includes the procurement of AI model training hardware. Next slide. And the upgrade of existing hosting infrastructure so that it can securely handle large volumes of data and AI computations. For sure, we'll need to recruit or train AI experts and data scientists and to strengthen the overall internal capacity of SHIFT staff to work with new AI tools. In the adaptation phase, we'll focus on data sharing protocols and on adapting AI models to the Uzbek context. That means aligning them with local norms with the classificators, ICD-10, DRG codes, tariff catalogs, and other national standards. We will also integrate the models into the existing MedBank test environment via secure APIs. Training SHIFT staff to use the AI tools and setting up an AI monitoring dashboard also central in this phase. For the pilot phase, we intend to start in the same Sirdarya region where we already have experience with health insurance pilots and where the population size is manageable, around 900,000 people. And there we plan to select 2 or 3 hospitals and process around 2,000 inpatients claim with AI support. Later could be extended to outpatient or primary healthcare institutions. During the pilot, we will track metrics such as accuracy, time needed for claim adjudication, coding consistency, and of course we'll compare AI-supported processes with traditional ones and gather feedback from SHIFT staff and provider. This goal is to learn and refine the model and adjust workflows before scaling up. Of course, the last phase, if the pilot is successful, we'll gradually extend AI-supported models nationwide with iterative model retraining as more data become available. And finally, to conclude, Uzbekistan now is at a critical moment in its health financing reforms. We are moving from pilot region to a national health insurance system, and we are building now the digital foundation that will support this transformation. We understand that artificial intelligence is not a magic solution, but it can become a powerful ally if we invest in good data, in information system and human capacities. So for us, for Health Insurance Fund, AI is a way to enhance strategic purchasing and to improve the quality of claims processing and to support informed policy decisions for the benefit of our citizens. Thank you very much for your attention.
Thanks so much, Mircea, for this comprehensive presentation. I would hand over directly to our next presenter, to Sif Iqbal, who will present for the State Life Insurance Corporation of Pakistan. Over to you.
Good afternoon, everyone. I am Tosif Iqbal. I'm an actuary from State Life Insurance Corporation of Pakistan. I'm delighted to be here today to present Pakistan's perspective in this global discussion of AI in health insurance and how we are positioning ourselves in our systems for the future in AI. Next slide, please. I'll start with the background in social health protection schemes, how Pakistan has expanded its health insurance over the short span of time. Like we have started in 2016 with the PMT, with the beneficiaries covered in the PMT score, and then it expanded to universal health insurance in 2022. When we start, it was about only 4 million families that were covered, and later on we have covered around 75% of the population. State Life is one of the largest health insurance provider, which has a network of empaneled hospitals across Pakistan, and we have evolved ourselves with the digital systems that has grown in time, that we have been able to provide the insurance services in the very short span of time to the 75% population of time. Next slide, please. Digital systems. We have digital operation pillars, like we have managing the beneficiaries enrollment system, patient care system. Then we have the claim processing and service providers management, complaints management, and monitoring evaluation. These are all developed in this last 5 to 6 years, and we have real-time dashboards for all the monitoring systems, and we have business intelligence tools which can provide the for the fraud control and for the timely processing of claims. Next, please. About Pakistan's social authority infrastructure, we have the data management, like we can provide the services to nationwide, and we have the medical record system, which have the data-driven diagnosis analytics. Real-time dashboards are available to the service providers and the clients. And we have the quality access to healthcare system, which have the hospital profiling, and in the hospital empanelment system, we have the record of each hospital, which has the dashboards and their picture records, like how their system is evaluated and assessed on the basis of grading of the hospital. And we have their tariff management system based on their grading. Similarly, we have a patient care management system, for which we have the Android app, for which our medical team goes to the beneficiaries and record their feedback on how the treatment is provided to the beneficiaries, and how it is managed. It is the cashless services we are providing to the entire population, which is covered under the universal health coverage. And through this mobile application, they can record the services provided to the beneficiaries. If there is any complaint management system or any complaint related to the services, it is handled through this app, and it is already integrated and synced real time to our servers, from which our complaint management team contacts to them, and if any issue is there, they can resolve in non-time. Next, please. About AI journey in Pakistan. We have developed during this time some AI applications, which we have we are providing services to beneficiaries through 1,000 Implanted Hospital in Pakistan, for which we have some services related to cardiology services. Like if a patient is treated for cardiology, like angioplasty or angiogram, we have the CD recordings of these patients treated. And our AI application can detect and read all the images for every bit of the images. And if it can find that if this image is found in the database earlier, like if we have a angiogram, a CD of angiogram, and it was presented like some years ago, and we can find that it has been duplicated to detect the fraud control. If there is any duplication on the images, this AI application can automatically detect and alert us about the duplication. Next, please. Similarly, we have along with the social health protection scheme, we are also having the corporate health insurance business, for which we get the reimbursement process through the mobile application. We have a mobile application for the beneficiaries, for which they can submit their reimbursements documents scanned. If there is any forgery, or they can provide this application can provide any deduplication of the records. Like in this case, the case was submitted by another beneficiary, and the similar case was submitted from another beneficiary. So this AI application can detect and alert us on the duplication of the claims. Next. Similarly, we have a mobile application, and every beneficiary has to register themselves for the mobile application, for which we have to validate the identities. They submit their CNIC, and our AI application reads the record from this CNIC image and automatically approves the process and activate the application for this beneficiary from the provided image. Now we are in the process of developing an AI application for which we can automate our claim process. Like in this case, we are starting with the cases of dialysis. For dialysis, like we do not require any such OT notes or any detailed notes on the treatments. We just need how the patient was presented with the pre-dialysis weight and the post-dialysis, and some investigations are studied. So by this application, we are in the process of automating the claim process for the dialysis beneficiaries. Like it will study the images provided for the dialysis treatment provided. If you can go the next slide. For this application, it will provide the case summary and any diagnoses which are provided from the diagnosis detection from the test or labs that are attached, and it will also summarize the case, like how was the patient before and after the dialysis. Next slide. And if there is any red flags, like this AI application will detect any noting on the sheets, or if, as we are providing the cashless services to the beneficiaries, and if there is any case that cash has been charged, it will this AI application detects from the noting that there is some notes provided by our medical team that some cash has been charged, and it should be reimbursed to the beneficiary. Then this AI application will provide the red flags and any concerns that can be processed by the team. Next. AI is the for our future strategies, we are trying to develop, we are in the process of developing the claim automation process. Like I mentioned in the previous slide, that we will go with dialysis cases. We will provide some, we are in the process of finalizing the AI application that will automatically process the claim for dialysis patients, starting with the dialysis. And if goes well, then we can expand it to the other treatments as well. Then we are in process of linking the AI findings with the business intelligence. We have some AI. We have some business intelligence tools for which we have rule-based engines where it can be detected that if a treatment cannot be done after a certain treatment, it will provide an alert, and our medical team checks it. And we are now in the process of linking it with the business intelligence, linkage of AI with the business intelligence. Similarly, we are in the process of integrating EMR data with the hospitals. We have started piloting with the two hospitals, like all the system will be digital. At the current stage, we are getting the scanned documents for the claim processing, but we are now piloting with some service providers, like everything will be digital. They through the data will be transferred through APIs to us that for claim processing, there will be no documents involved in it, and it will be all digital. Similarly, we are in the process of implementation of AI-based solutions for our service delivery, and desk monitoring of our staff. But thank you. Thank you for listening. And Pakistan's health insurance digital journey obviously has taught us that this strong data governance and smart communication can dramatically improve transparency and cost control. And we are in the process of developing some AI application which can improve the claim processing and fraud control for health insurance system.
Thanks so much, Tausif, also for sharing some really concrete AI applications in Pakistan. With a look at the time, I have to be a bit strict. We have one more presentation. I would welcome Ariel Pascual from the Office of the President, Philippine Health Insurance Corporation, to present. And to the audience, please share your questions in the Q&A. We try to answer probably in written. We might not have that much time to answer question after the panel. So please use that chat box. Over to you, Ariel.
Thank you, Constance. So good afternoon and good day to everyone. I'm Ariel Pascual of PhilHealth, Philippine Health Insurance Corporation. So next slide, please. So I'll be quick. Just a few background for the Philippines. So Philippines in numbers, we have 112.7 million in population, wherein the average household size is 4, and the average monthly wage is roughly $330 or 18,400 pesos. We have a poverty rate of 15.5%, and as you can see, the poverty threshold is roughly around $240 to 273. So it highlights the fact that the financial risk protection should be the main priority of PhilHealth. Next slide, please. So Philippine health system, we have it is decentralized, wherein PhilHealth covers for the individual-based services, and these are the primary care, inpatient, and curative. For the population-based services, we have the Department of Health, the national government. It covers for the high cost, hard to procure commodities, and interim support for new interventions. And lastly, the local government. They cover for population-based services for local implementation. So services with existing PhilHealth benefits are covered also by the local government, or some. So we also have a mixed public and private system, wherein a few issues with private systems that we have unregulated balance billing, the private insurance or out of pocket on top of PhilHealth. So we have coverage for PhilHealth, and then we still have out of pocket on top of it. So we have free market for specialists also, fee for service, and for public, commodities are frequently out of stock. Physicians are salaried, and for public facilities, they often reach overcapacity, and low capability for higher technology services. We have multiple financing sources also, wherein we have 44.7% coming from government schemes and compulsory contributory healthcare financing schemes. 42.7%, those are from the household or out-of-pocket payments. We have also 12.6% voluntary healthcare payment schemes, as much as possible, we want to lessen the out-of-pocket payment of Filipinos, and that's the goal for PhilHealth. Next slide, please. So, as for the Philippine digital health landscape, we're actually roughly in the average. We have a score of 4, no? And these are because of the national strategies and policies. We have the UHC Act and the PhilHealth Framework. And here we have the establishment of the National Health Data Repository. I'll be touching on that later on. We have also ongoing legislative initiatives on digital health, and we have the DOST, or the Department of Science and Technology, PCHRD discussions on digital health transformation. So for the Philippine landscape, we have the DOH, and PhilHealth is in collaboration with the DOH, the Department of Health, the DOST, and DICT. So moving towards digitalization and upgrading our systems is being done by other government agencies as well. Next slide, please. So the current status of AI in healthcare is not really far-fetched, or it's not really new per se, but I guess we have limited presence still. So mostly clinical application when we for imaging and diagnostics, and most often than not, they are privately led initiatives. So with that too, we have limited data availability, standardization, and completeness. As I said a while ago, it's not completely new because we used AI also during the pandemic. Adoption of case management systems and contact tracing, chatbot technologies, and telemedicine services greatly helped the Philippines in combating the pandemic. So we have also existing platforms as foundation for future applications. We have the eGov Super App, which is the government's initiative to have this application wherein we can tie up multiple agency systems. We are also in the process of enhancing our own systems, current PhilHealth systems. And from the Department of Health platforms, we have the iClinicsys, which is the EMR used for government facilities, and iHomeis. Next slide, please. So, example for existing platforms as foundation for PhilHealth, we have the HCI portal, or the Healthcare Institution Portal. Here we have the YACAP empaneled members list. I'll be also discussing about YACAP in a few moments. So YACAP health data records, no, this is where we get them. And we have also the IPAS, or Integrated PhilHealth Accreditation System. So YACAP provider data, accreditation information are stored here. So I mentioned these systems because we're not only talking about just the benefits, a benefit package. We're looking at the whole picture. We're looking at the whole patient journey, which will be covered by PhilHealth. So, and with that, we have also we're in the process of establishing our primary care and outpatient coverage in line with the universal healthcare. So we have PhilHealth YACAP. Next slide, please. So what is PhilHealth YACAP? Actually, YACAP is Tagalog for hug. No, it means YACAP. We have it for it means a Yaman ng Kalusugan program. Quick information. YACAP stemmed from the previous primary care coverage of PhilHealth, which is the PhilHealth Consulta. So we transformed it into YACAP. From before, the PhilHealth's role is to just pay for the services that was incurred for the patient. Now we want it to be a strategic purchaser, and we want PhilHealth to be like a trusted health partner of the patient. We want to transform also the health-seeking behavior of our members, wherein from before we have a reactive, wherein members just seek care only when they're sick, no, to make it proactive. We want to make sure that the members. We want to make sure that Filipinos stay healthy, and we get to diagnose them early on if need be. And also for before we have members have to go out of their way to seek care. This time we want to make it accessible to them. We want to make sure that Yakap or like PhilHealth is visible, and it's simple to seek care. We want to make sure that the primary care of PhilHealth is proactive, no? It's primary care driven that focuses on prevention, continuity, and long-term wellness for every Filipino. So next slide, please. So what's in Yakap, no? We have the expanded consulta services. That's what I mentioned a while ago. The primary care arm of PhilHealth. We also integrated with the existing specialty benefits. We are connecting all the building blocks now for the comprehensive outpatient benefit. We expanded laboratory and diagnostic benefits. We have cancer screenings included in Yakap, and of course, Gamot, which is the outpatient drug benefit of PhilHealth. And we want to shift from reactive again to proactive healthcare. Next slide, please. So here I want to show you guys how we view Yakap. A while ago, I said we're not looking at it to just being a benefit package. So we have this patient journey wherein we assess and we think of the patient's empanelment to the system, which starts with registration, wherein we ensure that the beneficiary is in the system. Next is the PCC assignment or the primary care clinic assignment and selection. We want to make sure that, say, for example, Ariel will have this Yakap clinic assigned to me, or actually I selected that Yakap clinic wherein whenever I have something to consult with, I can just go to this Yakap clinic. And then FPE conduct. Of course, we have to have that baseline information of say Ariel, no? And we want to make sure that it's conducted and completed, and we also introducing a Yakap empanelment slip signed by both the patient and the primary care clinic. With this, we want to make sure that the patient knows his or her responsibility. Yeah, we want to make sure that the patient knows the things that he or she can get in Yakap. And we also want to make sure that the providers know their responsibility in taking care of the member of the patient. And lastly, empanelment. So this opens the gate to all the other services that the member can get once he or she have selected his Yakap clinic for Yakap. No? So formal care relationship establishment, or the 4 C's of accountability, of 4 C's of care. No, so we have the first contact, easy access. And that's what I mentioned a while ago. You want to make sure that access points are easy, or like are spread out. Comprehensive, wide range of services, coordination, no, integrating care, and lastly, continuity. We don't want this anymore to be like we have members or patients who got lost to follow up, because now, instead of just paying for the services, we want to see the outcomes. No, we want to make sure that Ariel's hypertension is managed, or Ariel's diabetes is managed. So we're not looking at just paying for the services this time. The next slide, please. So before having AI into the program, we're already building the necessary foundation for it. We have EMR implementation, and we have EMR implementation. So we want to make sure that we have the structured or complete data fields. And this means that we have the data that we will be getting will be of quality. So we will have like accurate and consistent and complete data. So, and that will be important and needed when we have the National Health Data Repository. And that's the only, I guess that's the way for us to monitor the condition of the member, of the patient. Real-time encoding and digitalization of health data. we saw the importance of real-time encoding of the health information of our members. Why? Because it affects payment. It affects we consider also the providers. So we're not just looking at the members, we're also considering the providers. And for the providers, of course, we want to reassure them that they will be paid on time and properly. So data availability, so timeliness, relevant insights and predictions, and National Health Data Repository plus standardization, so data interoperability, so for integration and streamlining of data. We want to make sure that all the data that we can collect through the program and all the other programs of PhilHealth can be put into good use. And lastly, data governance, training and building workforce. So we want to make sure that data is consistent. So errors or missing fields are prevented. Because sometimes, we all know, like, right, data shouldn't be like just from nothing, or like everything should be based on something. The next slide, please. So there, I've shown you the patient journey. I've shown you the efforts of PhilHealth in setting up AI for PhilHealth Yakap. So I want to show you now how we see AI being integrated in the processes. So one, fraud, abuse, and detection, diba? We want to see unusual claim patterns. We want to see them immediately, so we can address them before it gets worse. No, so overuse and mismatches. I've also mentioned member data record management. So meaning from the learnings of PhilHealth from the old consulta, wherein we have like multiple PhilHealth identification numbers, or we have also ghost patients. No, we want to make sure that those instances, those scenarios won't happen again. And so 2 parts. Moving forward, we want to make sure it doesn't happen again. And for the current situation, we want to remove the duplicate pins, member data cleanup. We want to like really make sure that everything is aligned. Next, pre and post audit. So we want to ensure that claims match the epidemiological data, complete and valid claims, claims documents, identity and liveness verification. This goes with the intent of having tying up all the relevant information of one claim. So everything should be aligned, starting from say for example, Arel's PhilHealth identification number with the selected Yakap clinic, with the consultation and the medicines that was given to me, and the reports and the laboratory and reports. And next is the member risk profiling. We want to make sure that we enable the preventive interventions and targeted screening are monitored real time. And lastly, real-time quality assurance. So prescription checks, drug interactions, appropriateness of services, and care coordination. And these all combined with the vision of PhilHealth to have a fast, fair, and trustworthy PhilHealth, wherein hospitals or providers are paid on time. Fair hospitals deliver better care. Members get Filipinos feel secure in their health insurance coverage. So thank you so much. And that ends my presentation.
Thanks a lot, Arel. Thanks to all 3 presenters from the countries. I would hand over with no further ado to my colleague Raul, who will be the facilitator now for the panel discussion.
Thank you, Constanze. Interesting learnings from country examples and opportunities for utilizing AI to improve health financing processes. Insightful contributions from all our speakers. Thank you so much. Now we'll move on to a panel discussion. We have exemplary individuals who are supporting countries in strengthening health systems and financing. They'll help unlock emerging trends and early lessons on use of AI across the region. And most importantly, the safeguards that needed to ensure trust and equity. I have with me today Sol-Hee Cheong. Dr. Cheong is the Director General of the International Cooperation Department at the Insurance Review and Assessment Service, HIRA, in South Korea. She has conducted research in various areas, including health policy and financing, the Korean healthcare system, claims review, health quality assessment, and healthcare information systems. She also serves as the Senior Research Fellow and Head of the WHO Collaboration Center for Strategic Purchasing at HIRA. Welcome, Dr. Cheong. Then I have Saurabh Bhatrai, who leads the openIMIS initiative at GIZ's Global Alliances for Social Protection. In his current role, he oversees the Global Coordination Desk of openIMIS initiative, who has been a collaborator on this learning exchange and ECOS development. He guides the initiative strategic positioning, aligning software development and fostering partnerships. A wonderful individual and an expert who merges health systems with technology-enabled initiatives. We have Mohammad Ghulam Rafi from Bangladesh, who is serving as the medical officer in the Health Economics Unit of the Health Service Division in Ministry of Health and Family Welfare. He's been the focal point of the pilot health insurance program, Sasto Suraksho Karmasuchi, which has been subsidized by the government for below poverty line households. So we have a frontline leader who is tackling these issues on improving coverage through health insurance in Bangladesh. And welcome, Dr. Rafi. Most of all, we have the august presence of Dr. Eduardo Banzon. Dr. Banzon needs no introduction. He's been a well-known leader in steering health systems change across the region in Asia and Middle East. As the current director of health practice team at ADB, he's championing universal health coverage and providing technical support to countries across Asia and Pacific. Thank you all once again for being with us. Without any delays, we would like to start the panel discussion. I would like to move to Dr. Rafi to begin with continuing the exemplary contributions that have been said by countries. You have been at the forefront of implementing health financing reforms in Bangladesh and having the opportunity to be one of the participants of the learning exchange where you could interact with 6 other countries. From your observations, can you highlight for us what key enablers and preconditions are essential for AI adoption in health financing systems?
Thank you for the question. The first enabler I want to mention that is there a robust data ecosystem is needed, like for the digitalized health and financial data, where claims, enrollment, provider payments, service utilization are recorded. Then we also need standardized data formats and coding system like ICD-10 coding, national ID integration system. We also need interoperability frameworks that helps to enable data exchange between insurers, providers, and the government ministry organizations. We also need to develop our infrastructure and technology capacity building frameworks, because if we don't have reliable ICT infrastructure, cloud services, or secure data warehouses, we cannot achieve more success in AI adoption in health financing systems. Computer powering system and backup power for health facilities are also needed. we also need to invest in cyber security systems and secure the authentication protocols. We also need a skilled workforce, like we need data analytics, we need actuarial scientists, we need digital system analysts who are expert in using digital tools. So upskilling programs for frontline implementers like me who have been trained in social health insurance monitoring and evaluation, or any IT expert under my control for overlooking the SSK project. I have seen that skilled workforce is the main key enabler for adoption, AI adoption in health financing system. We also need strong institutional mandates, like our country has developed healthcare financing strategy 2012 to 2032. But recently we are updating it because when we started our journey back in 2012, the scenario has changed. Our poverty has been increased. Poverty, as for catastrophic health expenditure, is going up. Out-of-pocket expenditure for Bangladesh is 68.5%. So we need to reform our health system right now, and we are doing reform activities. Moreover, we need multi-stakeholder coordination across health, ICT, finance, and regulatory bodies, because without the all the support from different stakeholders, we cannot achieve it. And we also need to enable legal and regulatory framework so that data privacy legislation aligned with global standards are needed. Regulation for AI transparency, accountability, and risk management is important. And procurement rules that allow innovation-friendly pilots and public-private partnership in our health system is also needed for the enabling or preconditions that is for AI adoption in health financing system. I think I get all the points. Thank you.
Thank you, Dr. Rafi, for highlighting the issues around infrastructure and data security. Now we move on to hear from Saurav. With your expertise in supporting technology-enabled systems and working in LMICs, could you also share your observations on key enablers and preconditions for AI adoption? Maybe you could focus a little bit on countries that you have already been supporting, like Nepal and Cameroon.
Sure. Thanks, Rahul. And good morning, good afternoon, everyone. What the key points I think Dr. Rafi already pointed out, and we saw in the presentations as well. No, if you noticed Simona's presentation from the keynote, as well as every country presentation, there's a big focus on data. No, and in health financing operations, to use AI for health financing, I'm afraid I don't have very good news, because AI isn't going to take away the need for having robust data systems. No, actually, it's going to increase that need, because not only do we need good health systems data, but also operational data, things that we didn't used to collect in the health system before. Like we need data on claims, like times that claims come in, like how fast claims are being adjudicated, and all of that data is quite difficult to collect unless we have robust systems. And these are things that we're facing in Nepal as well. The openIMIS AI module is set to be used in Nepal for claims adjudication, and it takes a while to get the data cleaned and ready for use. We need to make sure that we have the data that is there. And then also in Cameroon, we're preparing, and we see the same problem. First, to use AI, we need to train the AI on how to adjudicate claims. And if we don't have any data on how humans are actually adjudicating claims, we don't have anything to train the AI on. So it's always quite interesting to see the enthusiasm in using AI, but then when we get into the nitty gritty, and everyone likes to talk about the fancy models, but it's the groundwork that needs to be in place, because if we don't know how we as humans are adjudicating claims, how are we going to teach the machine to do it? So we need that data. So again, just wanted to stress on the data quality point. And then again, as Dr. Rafi said, technical infrastructure. But here I would like to emphasize that when we're talking about IT infrastructure with AI, we're not talking about the servers or the machines that we used to talk about in for other digital health interventions before. Right now, we're seeing an unprecedented need for compute power. Okay, so if we solve the first problem, having data, how are we going to? We need heavy machinery, to use that term. Like we need very powerful computers to train the AI model, and these aren't easily accessible in the countries that we work in. So we need to find an approach. Maybe it's a regional approach on sharing compute. Of compute power that we can use, especially now that we're going into agentic AI. As well. And then the last aspect, again, already mentioned human capacity, but here I would like to stress, and what we've seen also in many countries is beyond the data scientists and the IT colleagues, we also need to work with the health workers to understand how to work together with AI. Like if we're trying to put off some tasks to AI, like things that a human would do, it almost feels that we need to do team building with the AI agent. Like the health workers need to understand how to leverage AI, the AI tools to work together with them, not replace them, but maybe some tasks can be taken up by them. So it's really also building capacity in health workers to understand what are the capabilities of AI and how to work together. So I think these again, nothing new from what Dr. Rafi said, but I would just like to stress these points that data, technical infrastructure, and human capacity is what we've seen as enablers, and what we need to work on in most of the countries that we're in. Thanks, Rahul. Back to you.
Thank you, Saurav. Very interesting thoughts there, trying to bring back the skill set and the capacities that we need as human beings and experts working in health systems and financing to be able to train the learning models in AI. Drawing back our attention to issues around equity and governance, I would like to reach out to Dr. Cheong. You have been at the forefront of health financing reforms in South Korea, and being a thought partner for the government. From your observations, what are the learnings for countries, especially on governance and ethical challenges that should be anticipated? Do you have any learnings on how these could be mitigated?
Yes, thank you. We can expect challenges related to inadequate regulatory mechanism, insufficient transparency, algorithmic bias and discrimination, cybersecurity risks, lack of accountability in clinical decision making, and digital inequalities. So to address these challenges, we need national oversight mechanisms and a clear AI oversight body. So I think it is very important. In Korea, the Presidential Council on National Artificial Intelligence Strategy serves as the control tower of AI policy. And while ministries such as the Ministry of Health and Welfare will play key roles in each sector. Second, government-level ethics guidelines for AI use in healthcare must be developed, and practical measures must be implemented to ensure compliances. I think the international organizations such as WHO or OECD guidelines is very helpful. Third, efforts must be made to ensure accuracy, reliability, and transparency in data collection and utilization. So these efforts include ensuring data linkage and interoperability among various organizations, including private healthcare providers, protecting privacy and cybersecurity, collecting accurate information, ensuring data transparency and lawful processing, and preventing data and algorithmic bias. Fourth, policies are needed to address inequality in access to AI technologies. This includes capacity building for healthcare professionals to use AI, as well as strengthening digital competencies among the general populations. So that's it. Thank you.
Thank you, Dr. Cheong. As we are already understanding the enablers and preconditions for supporting AI implementation, especially in health financing, I think examples from Korea are very useful and timely for other countries to emulate. And the support and emerging evidence from the country has been of great importance to many earlier, also in health insurance supported by HERA. As we move into an era of consistent collaborations between the governments, between the countries in the region and beyond, there is a lot of scope for countries to learn from each other. We would like to learn from you, Dr. Dodo. By ADB's work in the region, are you observing any trends in regional collaboration? How can countries collaborate regionally to accelerate AI integration? And are there any best practices that you already notice?
Thanks, Rahul. Interesting question. Okay, I think the fact that we're actually talking here is already regional collaboration. But more than that, what we need really is to understand is, but more than the sharing of experience, what you're actually helping here is, how do I call it, demystify AI. Part of the problem we start talking about AI and health is that it's like a magic word, It's like that it immediately creates an image that it's something new. It did not start in 2021, you're correct. Or it's something like that you need experts to do things, right? We sometimes it results into something where we sometimes miss out on what it's really all about. In a sense, I always argue it's something that's really essential for health financing. So why is it that? What's AI? AI essentially is that you got so much data, right? And AI became AI, that everybody's favorite, because enough data was moved into the world, enough data was captured into the world, that you started to have, in a sense, the ability now to rapidly process it, provides you, it gives you more, it gives you an analysis that's so rapid that you can't do before. It allows you to do analysis on all of that. And if you think about it, that's something we have been missing in health financing. I've started my work in health financing. We were the only thing we can do was pen and paper because there was no choice. I've been in a stage where we actually were doing Excel files, in a stage where you could not actually, where you have to buy expensive servers in order to keep all your data, where health providers can actually push back hard politically when you try to impose on them that they capture data electronically because everything was so expensive for them to do that. We're now in a world where we can actually capture data so fast and so well. And we're now in a world we can actually do analytics so well. And that's AI. That's what AI is trying to do for us. It's actually trying to do analytics, actually making data valuable to health financing institutions, actually making all this data that we're capturing, because the analysis becomes so fast that you could actually use it now in all of the process that you're doing in health financing. So we need to demystify it. We need to explain. Sometimes I wish we could just stop using the word AI in health and just call it a hyper-powered health financing system. Because for me, it's nothing more than that. It means basically now that people, and we have Marsha here, we have Phil Health here, we have Mohammed here, and great to hear that you're moving forward the Bangladesh health financing reforms. And of course, though, sorry, we got Uzbekistan, we got Pakistan, with what started with the Prime Minister's Health Insurance scheme, and now that's a whole lot being managed by the State Health Insurance Fund. But at the end of the day, you cannot run this health financing scheme if you don't get all of the information that needs to be captured. And the challenge has always been that is there enough incentive for you to get it? Is there enough reason for you to capture it? Can you actually talk to all your stakeholders? Why are you asking for claims turnaround time? Why are you asking for information on drugs and all of that? When you get this information and you're not actually using it. Right. So for a lot of times, a lot of other stakeholders will tell you guys are just asking for data just for what? Now with AI, you could actually use it for every step in the health in whether you're running health insurance or running a government system. And so for me, this is where what we should move forward on. If we get to demystify it and basically say, look, this is really making sure that we get all of the information that we need to ensure quality healthcare services is given. That we'll be able now with this information rapidly, just on time, be able to do analysis and provide and have this information govern help us in doing this, whether we're talking about claims pricing, whether ensuring quality of care, whether we're talking about fraud, then this is something that can move much more faster. If we continue to make it something complicated, we're calling it AI in health, which would need a lot of people to I don't know how many of your audience can actually understand what it means. Then we have a problem. And so that's going to be where our efforts are all. We will make AI something so simple that everybody understands it. And for me, it's simply getting all the information one time and making sure that information is rapidly analyzed so it could be used by financiers, by ministries of health to ensure access to quality healthcare services for all without financial hardship.
Thank you, Dr. Banzon. That was great, drawing our focus back to demystifying AI for health insurance and making it as simple as possible. And I think that's a great start where countries will come together, not only to seek support, but also learn from each other on the best practices that they have been implementing. These were great thoughts. Thank you all for sharing your observations with our audience today. I'm once again grateful to ADB for bringing us together to share these experiences from our collaborative initiative. The e-learning course will be available in early 2026, and I hope it would help policymakers and practitioners to accelerate reform in their countries and use AI, like Dr. Banzon said, in the simplest way possible to push for more coverage, to reduce out-of-pocket expenditures, and move towards financial protection and universal health coverage, as it sets the tone right for this year's UHC Day slogan, affordable care, and we are looking forward to achieving that by 2030. And we are almost at the end of this webinar. Thank you for being very interactive on the chat, trying to post your questions, which most of our experts have already tried to answer. I would also like to take this opportunity to share that the recording and the PowerPoint presentations from this webinar will be available on the ADB's website, and we will notify you on your emails for those who have joined here and then on LinkedIn. Now I request Dr. Banzon to share his closing remarks.
Sorry, Robert, I didn't realize I was supposed to close, but allow me to thank all of our speakers, our friends from Bangladesh. Mohammed, I was working with HCU 10 years ago with Asadul. And so it's nice to see that finally you guys are really moving forward with the reforms. And of course, our friends from Uzbekistan, looking forward, Mersha, to support the State Health Insurance Fund. You should have been there, but I got sick, but we'll see each other again. Our friends from Pakistan, Sarav. And of course, HERA has always been there. Of course, not last but not least, of course, the Philippines. I did that enumeration to highlight how much health financing reforms, UHC reforms are happening in Asia and the Pacific. But the reforms are really moving into not just doing things for the sake of doing. They're actually grappling, in a sense, grappling the best approaches to make sure that they're able to run the systems well. I expect these countries to leapfrog, to pole vault. Sorry, I'm following the Southeast Asian Games right now. To pole vault that they don't have to suffer some of the things that guys like me and Nishant and Aki, Rahul, when we've been working in this space where, as I said, I think we all grappled like how can we actually get people to enter data or to even to just to use, and we actually did analysis using Excel file. Imagine how bad it was. You guys have the opportunity now to data capture is so easy now, so much simpler. Data storage is so simpler now. You have cloud technology and all that. Your analytics with AI means you could actually get the information so fast. And in a sense, that means the challenge of achieving UHC is no longer a challenge for these countries. It's something that you should deliver by 2030. Globally, we have committed to UHC in 2030. The latest report is saying that it cannot be done. I say no. Asia will deliver on UHC. Rahul is smiling. It will bring Africa with us, but Asia has no excuse not to deliver in UHC. And with great people like you in the forefront on making sure that data is driving and informing those UHC reforms, we hope to have a webinar soon enough, about talking about how Asia has achieved universal health coverage earlier than 2030. Thanks again, everyone.
What a motivational note to end this webinar, Dr. Banzon. Thank you, everyone on this panel and today on this webinar. Once again, from Amref Health Africa, from Asian Development Bank, and the openIMIS GIZ team. I really thank you all for joining us today and having been able to witness the learnings from all the countries that have shared their experience here. Most of all, thank you all of you for sharing the challenges and the way forward and the opportunities that you see for improving universal health coverage in all your countries using AI and technology. Before we close, just wanted to request all the panelists and presenters to have their cameras on so that we can take a quick picture. Iris, are you taking the picture?
Okay, I will.
The speakers.
Yeah, the speakers. I don't see Akihoto on my screen, but hope he's.
Okay. 1, 2, 3, smile. One more. 1, 2, 3. There you go. Got it.
Okay.
Thank you all. Bye.
Bye.
Thank you very much,
Bye.
everyone.
Thank you.
Thanks so
Bye-bye.
much.
Bye.
Thank you.
Bye-bye.
Participants.
Bye.
Bye.
Thank you all.